Hello, everyone, and welcome to the webinar. My name is Tracy Cook with Sachs Healthcare Communications. For today's session, I'd also like to show our audience how you can send in questions throughout the webinar. Our speakers will try and answer as many as possible at the end of the presentation. I would like to introduce our moderator, Angela Craig. Ms. Craig is a critical care clinical nurse specialist for the ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She has rolled out a progressive mobility protocol in her ICU and is planning the go live of her hospital-driven mobility protocol for next month. Ms. Craig has lectured extensively at numerous conferences and webinars on sepsis and hemodynamic topics. She has also published the topics of sepsis and heart failure. Angela, welcome.
Thank you, Tracy, for that kind introduction. The title of our webinar today is Let's Keep Moving, Early Mobility in the ICU. Speaking on this very timely topic are two exceptional experts, Nicole Kupchik and Valentina Abrasia. Nicole has practiced as a critical care nurse for over 25 years. As a clinical nurse specialist, she has led numerous quality improvement projects, including those focused on resuscitation, sepsis and sedation, and mobility. She currently works as a consultant with Nicole Kupchik Consulting Incorporated and also works per diem at a local Seattle area hospital. Valentina is currently a graduate of the Doctor of Nursing program at UCLA School of Nursing with cardiothoracic intensive care experience as a clinical nurse at the Ronald Reagan UCLA Medical Center in Los Angeles, California. She has presented at national and international conferences on early mobility and ambulation of high-risk patients on ECMO, including frail COVID-19 patients on ECMO as well. Valentina has developed an evidence-based ambulation protocol for adult extracorporeal membrane oxygenation patients. Our speaker has disclosed the following relevant financial relationships. Nicole Kupchik is a consulting and on the Speakers Bureau for Baxter Healthcare and Stryker Medical, and Valentina has no relevant disclosures. We do have continuing education for nurses and respiratory therapists. A link to obtain this credit will be available at the end of the webinar, and this educational activity is approved for 1 contact hour for nurses and RTs. The accreditation statements are below, and support for this educational activity is provided by Dale Medical Products, and we would like to thank Dale for that. Now I will turn the presentation over to my friend and colleague, Nicole Kupchik.
Hi, well, thanks, Angela, for that. I'm really excited. This is a topic that, to me, it's so utterly important. And I led a big project at a local hospital here in Seattle about 12 years ago, where we really moved from a culture of sedating patients, heavily running their RAS scores routinely -3, -4, to not mobilizing patients, to really lightening the sedation, getting patients up and getting moving. And I personally have a huge interest in the whole area of delirium. I was raised by my grandparents, and when my grandfather was hospitalized, he developed horrendous delirium. And it was really interesting at the time. No one really knew what to call it. And they called it ICU psychosis. We heard comments like he's crazy. We heard, it was really interesting how some people thought that his behavior was a baseline for him, and it wasn't. This was a gentleman who worked really hard, always held 2 jobs to support the family, and he was hospitalized. And I will tell you, he had horrendous delirium, was reliving World War II, and when we got him home, he was never the same. And he died 3 months later. And and one of the reasons I got into nursing was 3 years after that, my grandmother died of a medical error at a hospital. And I've always made it my goal and my passion to make healthcare safer. And I really, truly believe by doing appropriate sedation and getting patients up and getting them mobilized, we do make it a safer environment for them. And so learning objectives, we're going to talk about the benefits and barriers of early progressive mobilization in the ICU. I'm going to briefly touch on the A to F bundle. I shouldn't say briefly. I'm going to touch on the A to F bundle, and we're going to talk about the ICU liberation bundle and just how it can lead to improved care. I'm also going to talk about how different protocols can safely, you can basically support patients in a safe manner to get them up and get them mobilized. And then I'm so excited to be joined by Valentina, who is going to talk about her protocol at UCLA. She has spearheaded just some amazing work at UCLA and is going to share their protocols with you. So here are some interesting facts: is that about 3 out of 4 patients who undergo mechanical ventilation will have difficulty performing normal activities of life a year later. Like, really let that sink in. I mean, that's quite profound. As many as 95% of those who develop ICU acquired weakness still have health issues related to their hospitalization 2 to 5 years later. And long-term patients who experience delirium are more likely to develop acquired dementia after their illness. And we are seeing more and more publications about this very fact. And it's I'll tell you, one of the things I'm hoping that will come out of this last pandemic is some sort of support for patients after they're discharged from the ICU. It's quite fascinating when patients get discharged to home after having a critical illness. No one knows what to do with them. And one of the good things that is happening from this pandemic is the formation of after hospitalization, after critical care, post-critical care type clinics. And so I'm really hoping this takes off so that we have someone who can consult with these patients and really help them on their journey to recovery, because it doesn't end when patients are discharged from the hospital. Their recovery extends for years following. So you can't talk about mobilization without getting a really good handle on delirium. So, what is delirium? And, it's defined as a disease-induced syndrome. So we know it's not simple. It's actually very, very complex. But it's defined as an acute mental status change that develops over hours to days. And clinically, what we'll see, it's characterized by decreased attention, disorganized thinking, patients don't sleep well, they have either increased or decreased psychomotor activities. I will tell you, a lot of patients have delusions, illusions, hallucinations. And just 2 weeks ago, I was doing rounds in the ICU where I work, and we were doing CAM assessments. We were basically doing a prevalence study and using a delirium assessment. And I could not believe, so first of all, I feel like a lot of times at the bedside, and this has been no matter where I've worked or I've consulted, a lot of nurses feel like asking what day is it, what year is it, what time is it gets to delirium. And I think a lot of people think, well, if they can answer those questions, they don't have delirium. But remember, delirium is characterized by inattention and disorganized thinking. Asking what day is it, what year is it, what time is it, where are you, what's your name, doesn't really get to that. And it was fascinating. Just 2 weeks ago when we were doing these assessments, I had a few patients that were CAM negative, and I just said to them, just be sure if you're, having nightmares or you feel like you're seeing things, just let the nurse know, because that could be a sign that your brain's starting to get foggy and you're developing delirium. We had 3 patients out of 20 who admitted to feeling like they were seeing things. One person thought they were seeing spiders. We had another person who asked, like, if we they thought that they were seeing like gremlins. And I'm like, this is the thing, we need to ask questions and give patients permission to tell us when these things are happening. And then one of the other characteristics of delirium is patients can wax and wane. So they can wax and wane between being delirious and not delirious, and they can wax and wane between hyper and hypoactive delirium. But I think the bottom line and the way to think of delirium is that it's an acute brain dysfunction that's related to their illness, related to lack of sleep, related to just a huge amount of things that can affect brain function. And again, the 2 hallmark signs of delirium are disorganized thinking and inattention. Patients can develop hyperactive delirium, and we've all taken care of this patient, right? They're difficult to take care of. They're pulling out their lines, they're trying to get out of bed, they're a fall risk. Interestingly enough, most delirium does not fall in that category. Only about 20% of patients experience hyperactive delirium, but that's the patient we remember because there are a lot of work to take care of. Far more active is, or far more common is hypoactive delirium. And this is that cute little lady in room 12 who's not going to ask you for a thing. She is just, she is not with it. She's just kind of silent, sitting there silently aspirating. And here's the deal. She doesn't know what planet she's on. And then if it's, this is the type of delirium that has a much higher mortality, and it's harder to pick up, and you've got to really use the right tools to pick up delirium in patients like this. But this is hypoactive delirium, which again is far more common, and patients can wax and wane between hypoactive, or they can wax and wane between being delirious and not delirious. We're learning more and more and more about something that's called PICS, or post-ICU syndrome. We know this can affect the patient, it can affect the family. Patients and families both can have PTSD related to their hospitalization. Anxiety and depression are also very common. But long-term, patients can experience cognitive issues related to their stay. And this can affect, I will tell you, you hear story after story about patients not being able to go back to work, or just having difficulty working full time, having difficulty paying attention, having difficulty remembering things, and they're so reliant on calendars and notes and things like that. But from a physical standpoint, they can also have a lot of symptoms, feeling breathless out of nowhere, having significant neuromuscular weakness. Can all of these things can really contribute to prolonged recovery. So in 2018, the PAD guidelines were updated. So back in 2013, we had the very first ever PAD guidelines, which focused on delirium. And PAD stands for pain, agitation, delirium. And then in 2018, the guidelines were updated to include immobility and sleep disturbances. And these are two very important components of just delirium prevention, and then really, if a patient develops delirium, shortening that time with delirium. And the way we implement just different strategies to decrease delirium is what's called the A to F bundle. And you also might hear it called the ICU liberation bundle. So all of this terminology refers to ways that we can minimize complications of being critically ill. And the ICU liberation bundle, called the A to F bundle, stands for, the A is assessment, prevention, and management of pain. We know pain can cause delirium, but we also know treatments for pain can cause delirium. It's quite a slippery slope. The B stands for both spontaneous awakening and breathing trials. Those should be paired. I cannot tell you, even recently, I feel like this last year with COVID, we've kind of taken quite a few steps back in evidence-based practices around mechanical ventilation. During COVID, we had to really, these patients were difficult to sedate. We went back to giving benzos. Even just, a few weeks ago, I saw a patient put on a breathing trial while propofol was infusing. And I think it's just really time. I feel like 2021 and 2022 is going to be getting back to the basics and reminding ourselves of what evidence-based practices are around mechanical ventilation. The C is choice of sedation and analgesia. We should be using short-acting sedatives like propofol or dexmedetomidine, and not using benzodiazepine infusions as a mode of sedation. Delirium, if you don't use specific tools to assess for delirium, we're really not going to pick up on it. Ideally, though, we'd like to prevent delirium, but if a patient develops it, just remembering those things that will help shorten their delirium incidence. And then getting patients up and getting them moving is the E in the A to F bundle is essential. And that's what we're going to focus on here today. Now, I'm going to admit I'm not doing a huge focus on the F, which is family engagement and empowerment, but I just think it needs to go without saying the family needs to be involved. In fact, a recently published study by Brenda Pond and a group that looked at, they evaluated delirium incidence in patients who had COVID-19. One of the independent factors that decreased delirium was family presence and family engagement. And we know that this was really missed and minimized during the pandemic. And I mean, for obvious reasons, but having family at the bedside is absolutely essential. So when we look at the A to C portion of the A to F bundle, we know that we should pair spontaneous breathing trials with spontaneous awakening trials in patients who are mechanically ventilated. When we do SBTs and SATs daily in patients who qualify, we know that we shorten the ICU length of stay. We know that getting patients off sedatives and getting them off the ventilator is going to really help decrease the risk of delirium. And we know using benzos is going to increase the risk and incidence of delirium in patients. But I think one of the things to really help get us there is having some sort of a protocol and really cultivating a culture of minimizing sedation, keeping patients a little more awake on the ventilator, getting them up and getting them mobilized. You know, and then when I first started as a nurse in 1993, we used to call it bag and drag. We honestly did not use heavy sedatives in patients who were ventilated, and we'd get them up, and we called it bag and drag. We'd get them, meaning bag with the on the ventilator, and drag them, mobilize them through the ICU. That was kind of our slang term for it, right? But then in the mid to late 90s, we introduced benzos, and benzos were amazing, right? From the nurse's standpoint, because patients were they laid quietly in bed, they didn't move. The benzos lasted a long, long time. And then in the early 2000s, I have to say, I'm going to credit at Vanderbilt University, Dr. Wes Ely and Brenda Pon and everyone at Vanderbilt for really making us start to pay attention to delirium and the long-term effects of delirium. So just in general, if you're trying to decide, should I give an analgesic or a sedative? You know, the preference is for an analgesic over a sedative. If you're going to use a sedative, again, it should be a short acting sedative like propofol or dexmedetomidine. And you want to always titrate to the lowest effective dose. So every day, your goal should be to shut off the sedation if the patient qualifies. And then if you have to restart it at half the dose or reduce the dose. And one thing in healthcare we know is that things easily go up. Everything that goes up must come down. And we are really good at cranking things up, but sometimes we're not as good as bringing things back down. So in the D in delirium, if you've got a patient who's got delirium, one of the things we should ask, are we using the right sedative? Are we using minimal amounts of sedation? Do we have a daily target for sedatives? Do the sedatives need to be changed? Are we remembering to assess for pain? And then also thinking about other things that can contribute to delirium. So for example, shock definitely contributes to delirium. Encephalopathy from hepatic failure, renal failure, neuro injuries. Hypoxia can definitely contribute to delirium. Infections, we know that there's an encephalopathy that comes along with sepsis. Immobilization leads to delirium. And again, it's just so important to get patients up and get them moving. Doing things like putting glasses on patients or hearing aids. I mean, how many of you are completely dependent on glasses? Now, imagine somebody takes away your glasses, you're in a foreign environment, maybe let's add 20 years to your age. It would take no time at all for any of us to get a little wackadoodle. And then electrolyte imbalances, sodium and potassium are big ones that can also contribute to delirium. So published in 2019 was a study by Brenda Pon and a huge group in the Delirium Collaborative, the ICU Collaborative. And basically they evaluated the effects of the A to F bundle compliance. So all of those things I just talked about. And what they found and what they were able to identify is that when we got patients off the ventilator, their delirium incidence decreased. When we let's see, so percent of eligible A to F bundles performed. So when we stuck to the A to F bundle, delirium decreased, physical restraint use decreased, coma decreased. Other things they found, so these are forest plots, and anything toward the right of this line, this gray line here is considered favorable. So we can see the more that we comply with the A to F bundle, the higher the likelihood of getting discharged from the ICU earlier, getting discharged from the hospital, and then decreasing mortality as well. So if we stick to this A to F bundle, a lot of the outcomes will improve. So the higher we stick with the A to F bundle, the decreased incidence of ICU readmissions. The more we stick with the A to F bundle, the decreased incidence of being discharged to an extended facility or rehab versus being discharged home. More people go home when we follow these bundles. And there are just kind of getting back to mobility, there are massive benefits of mobility. We see decreased skin breakdown, decreased pressure ulcers. We see less deconditioning of muscles, decreased pain and contractures when patients are mobilized. From a cardiac standpoint, I will tell you, if you've got a patient who's on vasopressors, when I'm talking like stable vasopressors, so they've kind of been stable, getting the patient's feet on the ground and standing them sometimes can help you get those vasopressors weaned off, because engaging muscles in the legs is going to help increase venous return. We know getting patients mobilized decreases the risk of DVT. From a pulmonary standpoint, patients can expand their lungs if they're in a good position, if they're getting up and getting out of bed. It improves their lung capacity, decreases pneumonia risk, improves oxygenation. From a neurologic standpoint, we know that mobility decreases delirium, decreases depression. And from a GI standpoint, it just gets things moving and decreases constipation. So there are so many benefits of mobilization. And I want you to really think about the statement I'm about to say. And that is, immobility causes patient harm. Truly, leaving a patient laying in a bed like you see here can lead to patient harm. Now, does that mean we need to get everybody up and mobilized? I mean, no, there's some patients we can't. So if I'm on 100% and 20 of PEEP and I'm prone, obviously that's not the patient we're going to get up and get mobilized. But many patients in our ICUs do qualify for mobilization. Now, I want to visit what's considered kind of a landmark trial that was performed by Dr. Schweikert et al. And was published back in 2009 in Lancet. And this is a study that made a lot of us really think about the way we practice day-to-day management of patients in the ICU. And this was one of the first randomized control trials that evaluated early exercise in the ICUs. They enrolled 104 patients. 49 served in the intervention group, where they got these patients up early, so within the first 12 to 24 hours of admission, and they progressed their mobility. And then 55 patients were assigned to the control group, where they just kind of did usual care. And regardless, what they would do is every day pair a spontaneous awakening trial with a spontaneous breathing trial. And in the intervention group, they involved PT and OT, like I said, within the first 24 hours of admission in patients who were mechanically ventilated. And what they were able to identify is just absolutely mind-blowing. They got more patients. You can see this is the intervention group, this is the control group. More patients returned to independent functional status at hospital discharge, and this was statistically significant. ICU delirium decreased, hospital delirium decreased, and ICU acquired paresis at hospital discharge decreased. So there were major benefits in getting patients up and getting them mobilized. And you can see one of the other major benefits was ventilator-free days. They had more ventilator-free days in the group that got up and got mobilized early versus those who served as the control. And I don't know, for me personally, I'm just going to go back to this first outcome of return to independent functional status at hospital discharge. This is massive. I don't know about you, but me personally, just practicing as long as I have, I've been super clear with my husband. Any condition in which I am not able to independently function, I honestly, to me, there are worse things on this planet than death. And I've made it very clear to my husband, if there's any condition in which I am not able to ever get back to independent function, like, you know, I don't know, like, I've made my wishes really clear to him. And this is just massive when you think about just getting patients up and getting them mobilized early led to more independent function at hospital discharge. And not only did patients did they return to hospital function independence, but I think one of the things we need to understand is that in the ICU, we may not necessarily have seen that, because where you really see the turning point of return to functional independence is at about the 14-day mark. And for a lot of us who work in the ICU, we often don't see the benefit at that point. The benefit is seen much later. So we have to understand that everything we do in the ICU is going to affect that patient's long-term recovery. And that's just such an important concept to understand. But what we know is that when we get, and what we know from Dr. Schweikert's study, is that early mobilization was safe, it was well tolerated, it decreased delirium, there were more ventilator-free days, and patients were more likely to go home. That's just a huge, huge, huge benefit. So what are the criteria for getting patients up and getting them mobilized? And I highly recommend, if you are planning on implementing a progressive mobilization protocol in your unit, that you do have some sort of guidance for staff and some sort of a protocol. And this is the example protocol from the PADIS guidelines that were published in 2018. And so you can see here, so the first column, these are basically different criteria in which you kind of can get the green light to progress with mobility. If the heart rate's between 60 to 130, if the systolic is between 90 and 180, if the MAP is at least 60 to 100, if the respiratory rate is between 5 and 40, I was like, whoa, 5's kind of low there, but okay. But if the SpO2 is at least 88%, I know our unit, we went with 90%. If the FiO2 is 60% or less and the PEEP is less than 10, from a neurologic standpoint, if they're able to open their eyes to voice, if, you know, so I think it's just really good to have some sort of criteria, and then really to understand like when isn't a ideal time to mobilize patients. So so I don't know, like I think you don't need to recreate the wheel. These are some great criteria to start with, and then just tweak them for your unit. And so one of the things that the guidelines pointed out is that mobility sessions may be performed with the following. So, you know, if you're on vasoactive medications, as long as you're not actively titrating them, if the patient's stable on them, maybe it is an okay thing to put their feet on the ground and increase that venous return. And I'll tell you, like so many times I've seen us be able to decrease norepinephrine infusions when we get the feet on the ground. So what are some barriers to mobility? And this was a study that was published back in 2016. And probably the most common barriers to mobility, at least according to this study, were physical barriers. So if the patient's hemodynamically unstable, lines and devices can really be a barrier to mobility. Delirium, and I will tell you, I'll tell you a quick story in just a minute, but I kind of put the cart before the horse, as an old saying goes, when I co-led a big delirium project in our unit. And what I did was we got a big, basically a big what am I trying to say, like I got funding basically for a full-time PT in our unit to do a QI project, and so I got a $125,000 grant to fund a PT. And I mean, it was a full-time PT that was just for our unit, but she got there and she was like, oh my gosh, these patients are so delirious, there's not a whole lot I can do with them, and they are so deconditioned. So we realized, like, whoa, we need to back it up. We need to clean up the way we sedate patients. We need to really start preventing delirium so that we can get these patients up and get them mobilized. 18% of barriers to mobility are structural, meaning we've got just a lack of time, staff resources, you don't have a protocol in your unit, maybe the patients aren't, you know, they're not meeting eligibility. ICU cultural, a lack of buy-in. And I will tell you, having buy-in from your providers, respiratory therapists, the bedside nurses is absolutely essential. If people don't see mobility as a priority, they're not going to prioritize it throughout the day. And then I think, you know, another thing, sometimes if you've got patients and families who just really get the benefits of mobilization, they can also help in this process and help change a culture in a unit. And then 14% of barriers from this study, barriers to mobility, were process related, meaning that we don't have a plan, we have unclear roles and responsibilities, like whose job is it to get these patients up and get them mobilized. provider orders for prolonged bed rest are, a major barrier to mobility. And really the question we should be asking every day is what is precluding these patients to getting them up and getting them mobilized. Now, one of the things I really had to focus on clinically is just to have staff understand that mobilization doesn't necessarily mean that patients are walking miles around the unit. It could be starting with range of motion. It could be dangling, then progressing to standing, and then out of the bed into a chair, maybe marching in place with that. And then level 5 would be the highest level, including ambulation. So again, I just don't want people to get stuck thinking that it's all or nothing. Something is better than nothing. So sitting is better than nothing. Transferring is even better than nothing. And just really I think, take the burden off yourself and really let the patient help guide us as to what they can tolerate clinically. So what does it take? Well, people at the bedside, you've got to have obviously the bedside nurse. It's really helpful to have a physical therapist or a PT aide to help. In fact, one of the models we ended up going to was training a lot of our nursing assistants to be PT aides and having mobility teams that help with mobilization. Having family and loved ones at the bedside as well can help get patients up and getting them mobilized. For ventilated patients, it's essential to have the respiratory therapist. And we know this can be done. This is a picture of a woman who's on ECMO, extracorporeal membrane oxygenation. Valentina is going to talk about their mobilization program for ECMO patients as well. If we can mobilize patients on ECMO, we can mobilize just general ICU patients. This can be done. Now, one of the things that is absolutely essential is securing lines and preventing complications of dislodgement of various lines. I mean, it takes one loss of one endotracheal tube to really discourage bedside providers, nurses, respiratory therapists from getting patients up and getting them mobilized. So you've got to have really good securement devices. Same thing with central lines and pulmonary artery catheters. There are definite complications that arise from pulling out a central line. Patients can experience an air embolism. They can experience infection. You definitely want to make sure that you've got your bladder catheter secured. If you've got torque on that catheter, it can cause trauma to the bladder, which then can lead to CAUTIs. Other things, gastric tubes, dislodgement of those can lead to aspiration. So it is absolutely essential to make sure that you have equipment and securement devices stocked on your unit to prevent dislodgement of lines. So can we safely mobilize patients is the big question we ask. And this is a great study that was performed and published in 2017. And so it was a systematic review and meta-analysis that included 48 different patients evaluating 7,546 patients. And basically what they found was that these were potential safety events in over 22,000 mobilization events. The potential complication rate was only 2.6%. And again, I just feel like you have to set yourself up for success to prevent complications of mobilization. And so you can see the most common complications were hemodynamic changes. So maybe the patient gets tachycardic or drops their blood pressure or gets hypertensive. And then you can see desaturation events were pretty low as well. So all in all, the complications of mobilization are pretty low when you consider the benefits of mobilizing patients. So events that weren't able to be included in the meta-analysis, out of 22,000 mobilization events, 11 falls were identified, 2 endotracheal tube removals, and then 35 central line removals or dysfunction of the central line. So really the complication rate is pretty low. But again, you've got to make sure you've got all the things in place to make this a successful thing. So equipment, we ended up having to buy a lot of gait belts, and then we had to really teach the nurses and aides how to use the gait belts. I think it's essential to have a walker. This is one of my favorite walkers where it's got power and you can put suction for chest tubes. You could put your central monitoring, or I should say central monitoring, but like a a telemetry monitor on it. You can put your IV pumps on it. So really, really makes mobilization easy. And then you can hook, if needed, you can actually follow the patient with a wheelchair and hook the wheelchair to the back in case they need to sit down. But you need to just make sure you've got the appropriate equipment to successfully mobilize patients. This is actually a specialized bed that a lot of units use that goes from basically the horizontal to vertical position to get patients up and get them mobilized. This is a tilt bed, and you know, it really is a really nice assistance device that helps get some weight on that patient's feet to help them get to the point of mobilization. And then this is one of my favorite devices. This is actually me. This is not a glamorous picture of or a video of myself, but this is actually an in-bed bicycle device that basically you roll this into the patient's room at the foot of their bed, and patients can do active or passive range of motion on a bicycle. And it's really cool. Like they get an avatar, you put a helmet on, you can make it as interactive or not interactive as you like, but it's a really cool, just another adjunct to mobilization at the bedside. And then I think one of the things that is absolutely essential is when you do daily rounds with your teams, addressing all of the things that have an impact on long-term care. So are we controlling the patient's pain? Do we have them maybe on a non-opioid around the clock? Are we doing SATs, SBTs? What is their CAM score? Are they positive or negative? Are we getting them up and getting them mobilized? What was their best mobilization the day prior? How many times did they get up and get mobilized, etc.? And I just think talking about these things in rounds really helps create a culture that promotes mobility. So there are so many benefits of the A to F bundle, including liberation from mechanical ventilation, decreased ICU length of stay, decreased delirium, and the most important thing, patients go home. So with that, I'm going to hand it over to Valentina, who's going to share about her project at UCLA. Take it away, Valentina.
Thank you, Nicole. I will start my presentation underlying the fact that when mobilizing an ambulating patient in ICU environment, the concern related to patient safety represent the most common barrier. According to the literature, the use of protocol promotes a safer patient ambulation, better case selection, and planning for ambulation. Practicing teamwork routine helps the ambulation team to adapt and react in unpredictable situations. Next slide, please. Guided by the knowledge to action framework cyclical design with interdependent elements, the knowledge was inquired, appraised, and synthesized in the contextual background, generating the ambulation protocol. The original peer-reviewed articles focus on ECMO patients, ambulation safety, early mobility, and ambulation initiatives were appraised and selected. The literature search used medical subject headings via online biomedical libraries database at the University of California, Los Angeles, and Ohio State University Library. Studies indexed until July 15, 2020 were searched via PubMed, Embase, and Cochrane. Next slide, please. Yes. A synthesis table was elaborated with focus on clinical outcomes such as ambulation in less than 72 hours, ambulation distance, number of ambulation sessions, costs, disposition of patient ambulating on ECMO, cannulation sites, and safety events. As is displayed in Table 2, studies from case report to small cohorts demonstrated that early mobility with the goal of ambulation in patient receiving ECMO support is safe and improve clinical outcomes. Protocols elements such as planning for mobility and ambulation, stepwise approach, level of mobilization, evaluation criteria before ambulation, preparation were analyzed and included in the final protocol. However, gaps in the literature were identified, such as lack of standardized structured ambulation protocol. Variability was noted among the elements of ambulation initiatives. The patient's clinical outcomes were reported inconsistent or not addressed in the literature. As a result of synthesis of literature, the evidence-based structure protocol was developed using a stepwise approach that includes discussion of mobility and ambulation goal in IPT rounds, ambulation safety checklist, walk, and ambulation report. The discussion of patient mobility goals during the IPT round is important to bring all the team on the same page, and is based on the bedside nurse assessment and report during the interprofessional round. And an interprofessional team consisting of a bedside nurse, perfusion respiratory therapist, physical therapist, nurse practitioner, and intensivist are involved in establishing the eligibility of the patient for ambulation from the safety standpoint. This step allows the patient's preparation for ambulation, ensuring a balance between pain control, sedation, and patient mentation. Hemodynamics, anticoagulation, and cannula securement are also essentials to be discussed and addressed as the most common barriers for mobilization and ambulation. Planning of resources and timing is also addressed to allow the other participants to plan their workday. The ambulation safety checklist represents a cascade of checkpoints used by the bedside nurse to identify the points that needed to be fulfilled before ambulation. The checkpoints are already included in the patient assessment, such as Richmond agitation sedation score, confusion assessment method in ICU, or bedside mobility assessment tool. Other checkpoints very specific to ECMO patient population related to achieving an optimal anticoagulation, respiratory and hemodynamic stability are included in this safety checklist. If all the elements are fulfilled, we'll proceed with ambulation. If one of more of those elements are problematic, we'll assess, reevaluate, and consider alternative such as range of motion, passive and assistive range of motion exercises using a cardiac chair or using the verticalization therapy. If all the ambulation safety checklist elements are fulfilled, the ambulation team based on the needs is formed. Each member of the ambulation team will be participating during the briefing or timeout, and the team members will have assigned specific tasks for safe ambulation. However, all the team members would monitor the patient from the hemodynamics and respiratory stability standpoints, all the lines, tubes, drains, as well as the ECMO circuit to identify any bleeding at the site, any dislodgement, or decannulation. If any concern regarding patient safety aroused, the walk is stopped and the patient is placed in a safer position, and intervention to address the safety issue will be generated. The briefing will complete the ambulation, focus on ambulation achievement and events. At the end of the ambulation, an ECMO ambulation report, like a clinical report, will mention all the participants in ambulation, all the goals for ambulation, all the tasks performed by the team, and during the debriefing, we'll be focused on the achieving of the ambulation goal and any adverse events. To test the feasibility of implementing an ambulation protocol, a pilot study was executed from January to March 2021 when the ambulation protocol was applied to a prospective ambulating VA or VV ECMO patients 18 years of age or older in a 24-bed ICU from a tertiary and quaternary medical center with ECMO capabilities from the west coast of United States of America, compared with historical control group matched for the same dependent variables. 28% of ECMO patients deemed suitable for ambulation received the ambulation protocol and successfully performed early mobility and ambulation with very few minor safety events such pain, oxygen desaturation, oozing at the cannula site, in comparison with 10 to 15% of ECMO patients ambulating from the previous years. Prospective randomized studies are needed to evaluate the effect of ambulation protocol on patient outcomes. As an implication for practice, an ambulation protocol provides a structured stepwise early mobility approach, promotes evidence-based practice, enhances awareness about patient early ambulation, creates the premises for a safer environment for patients and nurses, promotes interprofessional team collaboration in optimization of ambulation process, and promotes standardized assessment, which set up the premise of a timely and appropriate evidence-based intervention that will increase patient safety and improve clinical outcomes. This concludes my presentation. Thank you for your attention. Now I will turn the presentation over to Nicole.
Well, thanks, Valentina. I know you all have done a lot of work at UCLA to really get with what could be a really difficult patient population, get them up and getting them moving. So, all right. Well, I just want to say thank you to everyone who joined us. We are going to take questions, so stay on the line. But just in conclusion, there are huge benefits, clinical benefits of early and progressive mobilization. Mobilization is achievable, but you've got to really set up an environment that promotes it. And that definitely includes having adequate resources like people, equipment, securement devices, etc. And just remember, patients that are lying horizontal, not mobilizing, causes harm. And that's really, I think, the way we need to think of it. So I wanted to share some resources with you as well. And there we go. Okay, so some resources. The 2018 PADIS guidelines, which I referenced in this presentation, just have so much rich content in them. I highly recommend, if you're really wanting to develop a program, to refer to those, because it does a nice synthesis of the literature. ICUdelirium.org is a super helpful website for either, and resource for either patients and families or for healthcare providers. And then I'm going to do just a massive plug right now. Kelly Dayton is a nurse practitioner who has an amazing Instagram page called @WalkingHome from the ICU. And then she also has a podcast that I just highly, highly, highly recommend, especially if you're trying to figure out just how to really make this part of your culture in your unit. It's a podcast that you will learn a ton. And then obviously the ICU Liberation bundle is essential in helping us move forward with this. So with that, I'm going to hand over to Angela, who's going to give you some information on how to get CEs, and then she's going to take questions from all of you.
Awesome. Thank you, Nicole and Valentina. That was awesome. Really enjoyed your presentation. I do want to inform our viewers on how to obtain their CEs for this session. This has been approved for nurses and for respiratory therapists. It's approved for 1 contact hour. And to obtain these CE credits, go to www.saxtesting.com/p. You will need to register at the site, complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. Once again, we'd like to thank Dale Medical for support of this educational activity. There is an archive version as well that will be available on demand at www.perspectivesinnursing.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. We do want to thank you for attending this webinar, and we're going to ask some questions now. And good to see your faces, everyone. And I've got some questions for you. So I just, first of all, someone has asked, what do you think of the walker one of the walkers you showed, Nicole, and I think you kind of alluded to it, but they also asked, have you tried the Nezi walker?
Wait, the which one?
It's Nezi, Nezzie.
I have not. I haven't tried it. Have Valentina, have you tried it?
Okay, and
No.
okay, that was from Kristen. Kristen, feel free to put something back in the chat box for us if you want to expound on that a little bit more.
Yeah.
But the walker that you were alluding to, Nicole, what do you kind of mentioned some things you like about it. Is there anything else that you would suggest?
Yeah, I think, you just need some sort of a mobility aid. And I think you've got to just be really cognizant of, like, if you've got somebody who's 6'4" and they're hunched over on a walker that's built for somebody my height, I'm 5'2", that's not going to work. And what I like is like how you can extend the handles so that patients aren't all hunched over all the time. So, and I think the same thing, like if you're going to buy chairs for people to get up and get out of bed, is really thinking about the height of that chair. Is it tall enough so patients aren't really having to work hard, to get up from a chair that's sitting too low? I think those are all things that need to be considered. And I highly, highly, highly recommend including your physical therapist when purchasing equipment.
Mm-hmm. Very good point. Very good point. Excellent. There's another really great question. You alluded to physical therapy, and how do you get physical therapy so involved? They mentioned that at their institution, physical therapy staff won't see patients on vents. They're not able to activate range of motion, and so that has to be nursing staff. I will tell you that at my institution, I met with administration and brought literally studies that showed about how important it is to have this done in the intensive care unit, and they bought it hook, line, and sinker. And so now we have a physical therapist in our ICU every day. How have you done that, Nicole? And then after Nicole, Valentina.
Yeah, well, I think it's having the conversation, right? Every state has got, I know PTs are limited in some states in regard to billing and what they can bill for. I know in a lot of places they cannot bill for passive range of motion. So you have to just kind of understand what the PTs are limited to, but open the conversation. And I completely agree. Like, I went to my hospital administrator and said, and I had a physician I work with who's amazing, Dr. Terry Huff, who really wanted to bring mobility into our unit and make it part of the culture. And I had some amazing nurses I was working with, like Kelly King, who's now in Chicago. And we were able to get a physical therapist who at a previous hospital had done mobilization. She was at shock trauma. And I think really it's having the conversation and then just finding out what are the barriers, because maybe they're thinking that every time they come to the ICU, they get turned down for getting patients up and starting mobilization. So I think it's really getting to the root and cause of, like, why aren't they involved? Maybe they think we don't want them involved, and just open up the dialogue is where I would start.
Yeah, absolutely. What about you, Valentina? Have you had any difficulties with physical therapy being involved in with your ECMO patients?
I would start saying the fact that the teamwork is extremely important when we are considering mobilizing all the patients. As I mentioned in my presentation, we do have interprofessional team rounds, and the physical therapists are one of the components of that team. We also rounding with a respiratory therapist, intensivist, and basically all the team. As you could see in my presentation, the bedside nurse is the one leading that conversation based on her assessment, and will initiate the discussion, and the team will participate in establishing the eligibility of patient for mobility. We never wait for the physical therapist to assess the patient mobility. They are excellent helpers, and they usually bring some safe handling devices with them. And I think the key word is teamwork and having all the stakeholders involved in the patient mobility.
Absolutely. And Nicole, I also resonated with one of your comments in regards to understanding physical therapy. You know, when we rolled out our program initially, it was just going to be that we did not even do consults, and that did not work. And the way they're paid has to do, at least here and in the state of Tennessee, had to do with us putting a consult in for them to evaluate and treat. So what we did was did a nurse-driven protocol where we can enter the PT order if they meet certain criteria. And boy, that's made a huge difference. So I think you bring up a very good point. You've got to understand the way physical therapists work for sure. Along the same lines, someone had asked another question. Do you have a uniform way of documenting patients' early mobility progress between RNs, therapists, and nurses? Their organization uses the AMPAC 6 clicks and the John Hopkins highest level of mobility to monitor patient progress. And that's an interesting concept to me. What are your thoughts, Nicole?
Yeah, I know we had worked with our documentation specialist to create like it's like an interdisciplinary place to document mobility, like to document mobility events and then best mobility of that day. But the other thing is we kept like bedside. We had a little clipboard and it would have like a calendar on it Monday through Sunday. And we would document every single day what their mobility events were. And this was focused just on mobility. And, you know, and I have to tell you, like, it takes a culture change, and a culture change doesn't happen overnight. In fact, you know, when we did this multidisciplinary quality improvement project, it took a good 2 years to get us to the point where we were changing our sedation practices, getting patients up, getting them mobilized, and it becoming more of a norm. It took a couple years. And I really honestly think that we all need to like brush off the dust post COVID and just understand, like, we did the best we could the last year. A lot of us got pummeled during the pandemic. And I think now is just a good time to kind of do a reset, evaluate your units, see what's working well, and just kind of revisit practices that maybe aren't evidence-based and just get back up and get on the correct pathway again. And I think, you know, as NTI it's a big critical care conference that happened a few weeks ago, and that was the theme of just a lot of nurses talking about the post-pandemic. I know some people are saying don't use that word post-pandemic, but just the post-COVID era of just getting back to evidence-based practice.
Yeah, absolutely. Valentina, do you guys have an interdisciplinary documentation tool, or are you guys kind of separately documenting?
I will start saying that the audience mentioned two excellent tools. I'm very agree with Nicole that it's a culture pro mobility that needs to be implemented in a workplace, at the workplace. We are working on implementing that charting, like to achieve consensus among documentation among providers. We do, for now, we do have separate sites where nurses or perfusionists or physical therapists are documenting, but there is absolutely a need to have it on the same clinical note and eventually in a activity progression chart for a patient.
Yeah, I love that idea. I've taken notes down for me. That's a good take home for me in this at this time talking about that. So here's another question. How about you guys with ventilated babies? Now, I don't know, I'm usually an adult person, but do you think it's important to get those ventilated babies moving as well? Does anybody want to talk about babies?
I will
I
take this
personally
one.
don't do babies. I'll defer to Valentina.
Yes, me too.
I think it's a hard question. I'm working in adult ICU for all my life, but definitely it's important. One of my committee member from my doctoral program is a PQ a nurse practitioner and pediatric nurse practitioner, and we had a discussion regarding this aspect, how actually you can implement such a mobility protocol in the pediatric population. It's definitely challenging, but I know the nurses can do it.
Awesome, awesome. And one last question. How often do you train your RNs, RTs, and PTs as a team?
How often do we train them as a team?
Yes. So in the process of progressive mobility.
Yeah, I mean, it's interesting. I don't know. We did training definitely around like safe patient handling and to minimize staff injuries. And then I know we included it in like nurse training when they started at the hospital, but I don't remember us honestly doing like a ton of training as the entire team. I think a lot of it just happened honestly on the job. Like we all
Yeah.
had our role, and I think it just evolved over time, and it just became part of the culture. I don't know, Valentina. I mean, you're mobilizing ECMO patients is a whole nother risk. So I don't know, did you do team training?
It's not per se a training, but definitely each team member, they are aware of this pro-mobility initiative. And when we participate in implementing ABCDF bundle in our institution, in our unit, we had that interprofessional collaboration opportunity, and definitely we get trained like a team and then share the same vision and same goals for the patient. For specific for nurses, we do have annual competencies training part, and actually the ambulation with physical therapists, respiratory therapists, and perfusionists, it happens on a daily basis. So basically, it's an ongoing process. So that doesn't really need a specific training. We do that briefing before ambulation where we are establishing the patient mobility goal for that session. Of course, we have all the assigned tasks. We are like practicing every day or with every move. And of course, our biggest concern is patient safety. We want a mobility event or mobilization to be safer for everybody. And the debriefing, it's another thing that's incorporated in the protocol, and that's really helpful to find the ways that we can improve.
Awesome. Awesome. Well, I think we've reached our time. You guys have been amazing. Thank you so much to both you, Nicole and Valentina. And I am going to turn this presentation over to Tracy for some concluding remarks.
Thank you, Angela and Nicole and Valentina. We'd like to also thank everyone for attending today's webinar. Immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. As well as for the CE Certificate of Completion, to obtain your CE credits, please visit www.saxtesting.com/P and register at the site and complete the evaluation. Again, we thank you for attending this session, and we hope you have a great rest of your day.